education was at the University of Rochester in upstate New York. And for those of you in the health profession space, you know that that's where the biopsychosocial model came from. And the theme behind my medical education was it's more important to know what kind of person has the disease than what kind of disease they have. And so it really dovetails with this person-centric approach. And we become so disease-centric. You know, my approach to this person-centric thing is literally the person. And as you'll hear me talk, it's the person as human capital and what they bring to the workplace and to life as represented in their human capital skills. The last academic institution I was at, which wasn't Stanford, but it was a well-known New York City institution. When I left there, there were 106 specialty clinics. They used to call them ologists. There were ologists everywhere, and virtually none of them had a view of the full person. So what I want to spend some time on this morning is in fact, let's see, where did my pointer go? I want to talk about the 5% population. And we know that in healthcare there are outliers. And you learn about the outliers from your insurance carriers, whether it's framed as being those that cost more than $100,000 or $50,000. Or in fact, when I first started in this, there was virtually a cap on all insurance of $1 million. And the assumption was that you couldn't spend $1 million in a lifetime. Well, we have a lot of people who spend $1 million now. Happens very frequently. But this 5% population is a really important population health index. That what I'm going to share with you is how can we understand the 5% group by looking at individual risk. And the 5% are a really interesting group of individuals in that they have risky overutilization of medications, testing, and specialists. For example, with this 5% group, what percent of them would you guess have had a narcotic pain medicine prescribed in the prior year? Yeah, 85 to 90%. And half of them have had a psychotropic medication prescribed at the same time. So we have this tremendous sort of overutilization, polypharmacy, that is accompanied by having poor access to and utilization of primary care and prevention. There's a significant utilization of lost time and workers' comp with this group. So the insurance carriers that are only telling you about the health plan are missing a significant piece of the puzzle. Typically, they have maxed out their insurance out of pocket, so utilization is free, so there are few economic incentives attached to their consumption of care. Also interesting that there's contagion in this group, meaning 5% people have significantly higher utilization in their family of dependents and children. So there's a contagion effect that is really important. And the last statistic that is really important, and our prior speaker spoke to this, I mean, you were in the 5% for a time. I can guarantee that. Being a gastroenterologist and knowing about colon cancer, you went in and you came out. And so there's roughly a 20% migration into this 5% population each quarter, which means people are migrating in, people are migrating out, which really opens the door for our being able to, let's see, Kimberly. Nope, I want to. There's a real opportunity for us to bring preventive strategies into the mix when you're looking at this population in terms of who's migrating in and out of the 5%. So some characteristics of this risk index that is person-centric rather than disease-centric is that, first of all, we calculate this using econometrics rather than actuarial science. I don't know how many, any actuaries in the room? Any economists in the room? Boy, I'll tell you, there's a real difference in being able to predict risk if you're using an actuarial method versus an econometric method. And the major difference is that actuaries use fixed demographics. Your gender, it's your age, it's your location. Whereas econometrics use things that influence behavior, like compensation. Actuaries never build calculations around compensation. And of course, the most important compensation in this 5% population is that the majority of them are collecting health-related disability compensation. So if you pay people to be sick, guess what percent might choose to be sick? Not insignificant. Not insignificant. And so of course, how much you're paying people to be sick, whether it's short-term disability or long-term disability or sick leave or workers' comp indemnity, very much influences the migration in and out of this 5% group. Secondly, this index, as you're going to see, is a predictive index. Cost is a lagging index. So by the time you get your high-risk outliers from your insurance carrier, it's because services have happened, cost is incurred, it's a lagging index. We need to get upstream in terms of something that is more preventive. Again, it's person-centric versus disease-centric. We have all kinds of risks that are calculated based on, do you have asthma, do you have heart disease, all of the chronic conditions. But as you're going to see in a moment, this 5% people don't just have one disease. They have 10 diseases. And so you've really got to deal with this in a person-centric way. It's comprehensive. That includes medical and pharmacy as well as lost time. And we currently use over 300 weighted risk variables. Here's an example of a person and the Human Capital Risk Index score. This happens to be a person where the primary variable is they have lung cancer, but they also have asthma. They're being treated with some respiratory drugs, some anti-infectives. They've been on short-term disability. They filed a workers' comp claim. Why might the workers' comp claim be of interest to a healthcare provider who are seeing somebody with lung cancer? The first thing you think about when somebody is an employee and they've got cancer? Might it be relation to work? Exactly. And so how might important that be to a provider in terms of understanding the risk of this person and their job? And so we routinely look at this kind of a profile on each individual. I'm now going to show you, if I can advance this. I need my helper here. If we translate this individual risk into population risk, and of course this is the huge debate these days, and what you see on the left is cost, stratified by the old Pareto concept, the 20-80 guy. And you'll see the gray bars represent a 50% population, 30, 15, and 5. What you see in the red bar is the cost of those 4 populations. The 5% people, way, way, way more costly than the 50% people. So what happens if you have a risk pool and that risk pool attracts just the 5 or the 15 percenters? I mean, what's being talked about with Obamacare these days? I mean, if you frame this in the exchanges in terms of the left being bronze, silver, gold, and platinum, if the plan happens to attract a disproportionate percent of 5 percenters or 15 percenters, those guys are going to have a problem that usually will take about 18 to 24 months to show, but they're going to be out of business. I was the medical director of the first federally qualified HMO back in the 80s. We had HMOs spring up everywhere, risk-bearing organizations. If they happened to attract average risk, they did well. If they attracted adverse selection, they did really poorly, and they were out of business. We're going to have a whole bunch of these exchanges where the risk migration calculated by actuarial methods isn't very precise, that are going to be in a terrible problem in 12 to 18 months when the actuaries finally figure out that they got an adverse selection of 5%ers or 15%ers. If you can't bring 50%ers into the mix, you've got trouble. So on the right-hand side, you see how the HUI score is predictive. Look particularly at the 15% population. You'll see that the HUI shows up considerably before cost does. So if you have a HUI score on a person, and I'm seeing them as a provider, it allows me to allocate resource differently. Meaning if the person that I'm seeing has got a HUI score of 1, which is average, or a HUI score of 0.5, they don't need the same attention as somebody who's got a HUI score of 2.5 or a 5. And so it becomes really important as a predictive. If we could deliver this information at a point of service to a provider, for them to have a much better sense of what the patient looks like as a person and as a more broadly based person. So let's see if I can get this right. So here are some indicators of this 5%, 95% group. This is a year's worth of data on individuals, and you'll see that the medications for the 95% are 3, for the top 5% are 10. Going back to my question, what kinds of medications? 85 to 90% of people in the 5% are on a narcotic pain medicine. Another 50% are on a psychotropic medicine, often simultaneously. And by the way, often prescribed by different providers. And so if you go to the providers and you've got 11 different providers, they don't really talk to each other, you know? Even when they're using a unified medical record. We've had a lot of experience. I'm sure there are folks here that know Kaiser Permanente. We know Kaiser really well. We know Geisinger really well. We know the Cleveland Clinic really well. And the reality is, even though they may have central medical record, doesn't mean that the physicians that are practicing are necessarily talking to each other, communicating with each other. It's what you are attempting to do in terms of getting them on the same page in terms of integrative health, is bring them together. The 5% have 13 unique diagnoses, 33 tests, and as you can see, their average cost for the year is $40,000 compared to $2,300. That's almost 20 times more. Virtually all of our cost increase in healthcare is in the 5%, not in the 95%. We are progressively spending more on fewer people because you put a foot inside the door of an emergency room with chest pain, and you end up with cardiac studies and coronary artery insufficiency and a stent, and you might only be there for 24 to 48 hours. What do you think the average cost is for that episode? Almost $60,000. So you immediately become a 5%er. If you go to the emergency room with coronary artery insufficiency and chest pain, and you've got a financially incentive system who's there with all of the technology to test you and to show that you've got some coronary artery plaques. I know I have a few. I'll bet many of you have a few that you don't know about. But if you're into the testing system, where the system is incentive to test you, and you come up with that kind of a diagnosis, the likelihood of your being in this high-risk group almost overnight is incredible. Now, look at the next to the last line here. This HUI predictive risk index is very different for the 5% as it is for the 95%. Look at the last line, which is self-report health risk assessment information. The same. On the other hand, that's the data that's being used by virtually every carrier and every organization in the country to identify who needs more service. Is a health risk assessment tool. It's non-discriminating in terms of identifying who the 5% are. So it's really important for us. And by the way, we've looked at virtually all of the common health and wellness HRA providers' data in the country. We have roughly 50 employers that we work with. So we've been gathering that data from some time in terms of these analytics. So this becomes a really important issue for us to, I now want to go from an individual risk to what we call a disease cluster comorbidity analysis. And what you see in the blue bar of these bar graphs are the clusters of disease that are most common in virtually every risk group. And musculoskeletal is far and away, with all of our work, the most common account. On the other hand, look at the difference between the blue and the red with people with musculoskeletal. Over half of the cost is not in musculoskeletal disease, it's in comorbidities, in stress and anxiety. It's in other things that people. So if you're coming at this from a person-centric way, it's a very different view than you're attempting to manage this from a disease-centric way. As you go across this, you see how striking the difference is between the red bar and the blue bar. Even cancer. Look at the fourth one. Even patients with cancer, the specific cost of cancer treatments is significantly less than the cost of comorbidities. So the medical system is very good at what I call piling on when you show up with a specific disease. I mean, we've looked very carefully at back surgery. And the physician cost of back surgery is by and large less than 30% of the total cost of somebody who's in the system being treated with back conditions. All of that extra stuff that happens. And more of that extra stuff happens if you're in institutions than if you're in private offices. Even though there are limitations to private offices, as we're sadly learning in terms of Joan Rivers, but you know, you hate to have something happen when you're having your vocal cords trimmed, if you happen to have an event. But the reality is when you're in institutions, and so when we compare institutions, it's the large medical centers that perform less well in terms of total cost value than the smaller institutions. I won't go there, but we've looked at the 25 institutions in Northern California, including Stanford. Guess where Stanford fits in terms of a cost-quality evaluation? Not at the top. Anyway, this becomes a really important index for us to understand. Now, so how do we apply this? It gets applied by bringing data in from benefit sponsors. And the most important kind of data that we collect to do this kind of risk assessment is human resource and compensation data. It's data about the person and their job and what they're getting paid. In fact, when we look at this population HUI score across 40 employers, what kind of employer do you think has the best population HUI score? And what are the variables that determine that? And I can tell you it isn't job type driven. It's driven by the composition of benefits. And particularly if you pay people to be sick, the richness of sick leave and disability benefits drives migration into this 5% tremendously. And so a firm like Whole Foods, anyone here know Whole Foods? They have a really good population HUI score because almost 40% of the wage that's paid to Whole Foods employees is performance-based, not guaranteed. You have to work for it. So if you have to earn your wage, you have to be what? Be on the job. You have to be productive. So you're very sensitive to these incentives and where you go for medical care. The worst score among all of our accounts is the state of Wyoming, where there is zero incentive compensation in the mix. I'll bet it's that way in California. So it becomes really important to produce the data that allows us to develop this risk score. And the risk score comes out of the analytic data warehouse. It's on demand available at a point of service for the healthcare professional. We're now delivering this point of service electronically, which is the focus of this discussion, through cloud technology to healthcare providers. What kind of providers do you think would really benefit from seeing a HUI risk score on their patient when they walk through the door? Yeah, especially primary care providers, health management providers, wellness providers, even orthopedists. We're delivering this HUI risk index. When a patient walks through the door, a button gets pushed, and this HUI risk index pops up, which gives that individual provider a sense of what kind of person they're dealing with, which goes well beyond, do they have diabetes, or do they have back pain, or do they have cancer? Now, those are built into it, but it becomes a really important informing of the provider at a point of clinical decision-making, which then generates patient-centric care. We've also had a good deal of experience now in distributing this human capital risk index to patients. What do you think patients do with it? Well, it's really interesting. They like it because a better HUI score, sort of like a better, if you will, score about your borrowing power. A better HUI score translates into better engagement, higher wages, all kinds of things that are beneficial to this person's human capital. And so it's been very interesting. We're now delivering to over 10,000 individuals through providers, a variety of providers, this human capital risk index at the point of service, which is very important in guiding resource allocation. The folks at Kaiser we're talking to have said, this is a game changer for us, because up until now, when you go through the door, everybody gets 15 minutes, whether they need it or not. But some people who've got a HUI score of 5 don't need 15 minutes, they need 2 hours. And some people who've got a HUI score of 0.1 don't need 15 minutes. And so it's very much informing resource allocation in terms of how professionals understand the person that they're treating at a point of service. And then, of course, this risk information, as you can see on the right-hand side, goes back into this integrated data warehouse. So we're able to evaluate performance of the provider. It's been really interesting. When we look at a list of hospitals or a list of primary care providers, and we're now able to, in a much more precise way, help them understand the risk of their patient population. You know, forever we as physicians have said, you can't evaluate me because you don't know the risk of my patients. Well, we've got a much better index now on the risk of their patients, and I can tell you there's always a 300 or 400% variation in the patient clientele of a given provider. And so now you can see how well they're managing the risk of an individual and a population of individuals. And there's almost a 400% variation in what that looks like. So if you're a consumer, and especially if you're a consumer that you've got some skin in the game through a health account, and you want to get to the best provider, wouldn't you like to know that information? Which providers are performing the best in terms of total risk management? That's the new frontier for the utility of this human capital risk index that we're now on the threshold with about 10 years of experience, and now pushing the envelope and getting it out to a much broader audience. And we think it's going to literally help us by fixing the 5% problem, address, as you'll see on the last slide here. The result of this, on the left-hand side, is a reduction in waste in our system. What percent of our system cost is waste? 30%, at least. Now, for us economists, we frame that as moral hazard, but it's really inefficiency in the system. It needs to be fixed with fixing the information problem. And so Most everybody who's willing to have an open mind about it knows that we spend 30% more in this country, but we're not 30% healthier. In fact, in many ways, we lag in terms of infant mortality and other health outcomes. But if we don't fix the 30-30 problem, it bubbles very quickly to the 10-2 problem. And the 10-2 problem is the inflation rate for health benefits in this country runs at about 10%. What's the growth rate in real-time wages? 2%. Boy, that isn't just a sustainable proposition for us. We spend more on Medicaid in the state of Wyoming than we spend in education. Boy, is that troubled? Or what? On the other hand, we know there's a very close correlation between education level and health status. But the opportunity cost of our spending more on health is we're not spending it on wages. We're now working with a number of nonprofit employers who absolutely struggle to put wages in people's pockets, while their health benefits cost trend through their insurance carriers is trending up at 10 to 12% a year. And you don't think that's a crisis for this country? What the big debate in Washington is all about, but are we getting any solutions coming out of Washington? I don't see them, and I'm pretty close to them. Turns out my Wyoming senator, Senator Enzi, is the ranking Republican on labor and health in Washington. I was very involved in the putting together of the structure of Obamacare. At least I was there critiquing it. They weren't listening. We have it, but we're now having it in a version of Medicaid in every state in the country. How much of a cost problem does California have with Medicaid? Huge, huge. And so we think that this outcome, which is reduction in waste, a decrease in specialty care and prescription drug costs, increase in person-centric primary care and prevention, increase in health as human capital, and cost savings so that resource can now be committed to wages, is the outcome that we would see from this telephonic distribution of this electronic risk index to providers at the point of service. So thank you very much, and I hope we will have some time for discussion.